Good morning, everyone. Please welcome Jason Henry.
Good afternoon. You know, I'm standing here by myself because my co-chair somehow is lost in the crowd and should be here with me. So, Becca, if you're out there, please come and join me. Did you guys have a great conference? No. That sounds like it was an okay conference. Did you have a great conference? All right. How many of you went to karaoke last night? I heard they had some great singers and the drag show was off the chain. Was it great? Awesome. We had, over the past 3 days, we had a very great conference. We heard from Dr. Park, and the DIS, who reminded us of the importance of the work that we had to do, and that we're doing. We also heard from Dr. Levine, who also shared with us the commitment from our federal government. And most importantly, very exciting, while she was speaking, they released the Doxy PEP guidelines. Let's give a shout for that. We now have guidelines. I've had the opportunity to actually go and visit some of the breakout sessions, and they were great, they were rich, and had wonderful information. We were able to actually meet with each other and network and share resources. I met many of you in the hallways and in sessions. Most importantly, this conference could not have been successful without you. So let me hear you give a round of applause and thank you for being here. Coming up, we will have our Doxy PrEP preliminary, and we look forward to a great session on that, and that should be great and exciting. But overall, again, thank you for being here. Thank you for your commitment. Thank you for all the work that you do, and looking forward to seeing you next year. Have a great day.
Please welcome your Engage partner sponsor from Hologic, Tara Gee.
Good afternoon. My name is Tara Gee, and I'm with Hologic. And today, as we close out this conference, on behalf of Hologic, we wanted to extend a huge thank you to the NCSD team for their hard work and their time that they put into organizing this amazing meeting. So, huge thank you. STI Engage has provided insightful plenary sessions, informative breakouts, and also invaluable side conversations. As we know, it takes a village to provide healthcare, and for us, we are so extremely grateful that we have the alliance in this room of labs, manufacturers, and also healthcare providers. So as we get ready to depart from this amazing meeting, we all have action items that we are going to take with us. And as we depart, we need to take the passion and also the positive energy from this meeting that we can continue the collaboration on STI prevention. And then lastly, I also want to extend a thank you to all of you who are in the room today for what you do on a day-to-day basis within your states, your counties, your cities, and with patients. And lastly, I just want to say that we are so excited and we look forward to STI Engage 2025 and happy Pride Month.
Please welcome Dr. Philip Chan.
Good morning, everyone. How are you? I heard I missed karaoke yesterday. I'm kind of bummed about that. So my name is Dr. Philip Chan. I am a primary care and sexual health physician from Rhode Island. I work for the Rhode Island Department of Health. I also serve as Chief Medical Officer for Open Door Health. It's the state's only LGBTQ health center in Providence, Rhode Island. And this plenary today is so timely, given that the Doxy PEP guidelines were just released. So I do want to thank NCSD for hosting this conference. Let's give them a round of applause, NCSD. And I do want to thank you all for your work out there. You know, this really is a team effort. I've always thought that, not just clinicians, but obviously the clinical sector, public health, academia, et cetera. So thank you all for attending and listening today. I'm absolutely thrilled. This conference is so timely. This plenary is so timely about Doxy PEP. I'm very excited that Doxy PEP really is going to be one of the main tools in the toolkit to address bacterial STIs. You know, we've seen, a lot of us have lived through HIV PrEP. We've seen how PrEP has become really one of the pillars, right, of HIV prevention. And I'm optimistic that Doxy PEP will be that for bacterial STIs. So we have two wonderful speakers today. We're going to hear from them just briefly. We have Dr. Lindley Barbie and Dr. Carolyn Deal. So Dr. Barbie is Chief Acting Medical Officer of the Division of STD Prevention at the CDC. And we'll hear from her first about the guidelines that were just released. So please join me in welcoming Dr. Barbie.
Good morning, everyone. It is really a pleasure to be here to give this talk today, especially as the day after our Doxy PEP guidance was published. That really worked out well, didn't it? I also want to acknowledge that I'm giving this talk on behalf of Dr. Jonathan Merman, who at the last minute couldn't attend. And I know he's sad to be here, but I'm really excited that I get to be here to give this talk today. So before I move on to give you an update on the final published guidance, I wanted to ground us in our epidemiology. And I know we've been talking about this all week, but let's make sure we're on the same page. We have seen massive increases in the STI rates over the past decade. And while there are some small blips there in chlamydia and gonorrhea cases, we really think this is an artifact of the COVID-19 pandemic and changes in access to care. And it doesn't make sense that those would be going down while we're seeing incredible rises in syphilis and congenital syphilis. Nearly a fourfold increase in 10 years among adults and adolescents, and a tenfold increase in congenital syphilis in the past 10 years. At the same time, we now have data from 3 large randomized controlled trials among men who have sex with men and transgender women that show that taking a pill, doxycycline, 200 milligrams after sex, reduces STI incidence. And these are consistent results and very large deltas. So chlamydia and syphilis was reduced by over 70% in all 3 studies, and gonorrhea was reduced by about 50% in 2 of the 3 studies, which is really an amazing breakthrough for biomedical prevention of STIs. As you all know, we have no vaccine or other biomedical prevention. At the same time, there is one study in cisgender women, the DPEP study, and unfortunately, this study did not show a reduction in STI incidence. The study was conducted in Kisumu, Kenya, among about 450 cisgender women who are on HIV PrEP. The authors think this might be due to adherence, although they had high reported adherence in the 70 to 80% of all sexual acts. Hair studies indicated that only about 30% were compliant with the doxycycline. But I think the jury's still out here. And here we are, we're going to transition now, taking that data to where it gets us to implementation. Published yesterday, the CDC clinical guidelines for the use of doxycycline post-exposure prophylaxis for bacterial STI prevention. So there were subtle changes in the language from posting of the draft guidelines on the Federal Registry notice in October of 2022. And the final guidance reads, as providers should counsel gay, bisexual, and other men who have sex with men and transgender women who have had a history of at least 1 bacterial STI in the last 12 months about the benefits and harms of Doxy PEP and prescribe Doxy PEP through shared decision-making. When Doxy PEP is prescribed, it should be prescribed as doxycycline, 200 milligrams taken once orally within 72 hours of oral, vaginal, or anal sex. And we gave the strength of a recommendation of A1 with a quality of evidence of A1 as well. There's very strong evidence here. We added some additional considerations based on the public comment, which was to clarify that any formulation of doxycycline is acceptable, that providers should provide enough doxycycline based on individual needs to last until their next visit, 3 to 6 months later. And at each subsequent visit, providers should assess ongoing need for Doxy PEP. We also want to reiterate that this is really part of a larger toolkit and should be part of a comprehensive sexual health package. At this time, we cannot change our bacterial STI testing recommendations because we don't have enough data. But we are going to continue screening every 3 to 6 months, both for bacterial STIs as well as HIV for those who are not living with HIV. We also want to encourage people to continue their other sexual health needs, such as prevention of using vaccines for Mpox and hepatitis B. Lastly, we offer some counseling points for patients prescribed Doxy PEP. First, in the discussion of the potential benefits, which we discussed with the study results, and the known and unknown harms. We talked about earlier in this conference how doxycycline can sometimes be hard to tolerate, and how many people have taken it and maybe vomited afterwards, like I have. There's also phototoxicity, so when you take it and go out in the sun, you need to use sun protection, and sometimes you need to sit upright and drink it with a full glass of water so that you don't get esophagitis. There's also the risk for the development of antimicrobial resistance in other pathogens and commensals, and some unknown risks about the microbiome. The second counseling point is the need to take doxycycline exactly as prescribed and only for its intended purposes. And lastly, all drugs have potential drug interactions, so providers need to ask their patients what are their drugs, including supplements over the counter that they may be taking. The other part of the guidance is that at this time, we cannot give recommendations for other populations, including cisgender women, cisgender heterosexual men, transgender men, other queer and non-binary individuals. We just don't have enough data. So that's kind of wraps up where the guidance is at the big level, and I hope you all take a moment to read it at some point in the coming week, or maybe on your travels home. But what I want to share right now is some of the really exciting data that's coming out from the population level. Many of you probably know that San Francisco instituted their own local guidance in November of 2022. And at CROI this year, in 2024, they presented data for the first year of implementation. I'm going to share that now. So here we're looking at two graphs. On the left is chlamydia, and on the right is syphilis. And in the purple line, on the left-hand side of the vertical orange line, is what the trends in case reports were happening among men who have sex with men in the jurisdiction of San Francisco, so population level data. And then they did an analysis to predict if everything stayed the same, what would happen with that trend. And that's the blue line that you're seeing to the right-hand side of the orange vertical line where the guidelines were released. And then they mapped what actually happened. And that is the red sloping line, which, as you can see, slopes down. And actually, there was a 50% reduction in chlamydia and syphilis cases among men who have sex with men compared to forecast, which is really, really exciting to see this happening on the population level. They also looked at gonorrhea, though, and did not see a decrease in gonorrhea. So same concept here in this graph. Unfortunately, they actually saw an increase in gonorrhea rates or cases. And I'm not exactly sure what's going on there. Maybe there's some differentials in doxycycline-resistant gonorrhea in San Francisco, but I think this deserves a little bit more exploration. They also looked at chlamydia cases among cis women to kind of compare and see what was happening in the rest of the community. And they saw an increase at about 2.5% per month over the course of November 2022 to 2023 in chlamydia cases among cis women. So not seeing the benefit and definitely increasing rates in other populations. So really exciting to see that maybe population level data, one jurisdiction, we certainly hope to see more going in that direction. But one of the concerns that many people have is about antimicrobial resistance. We know that use of antibiotics can breed antimicrobial resistance. So what do we know at this point? Well, the Doxy PEP study, Annie Lukemeier and colleagues looked at Staph aureus, which is a commensal pathogen that we all have on our skin and in our nose, and looked at both colonization, which is kind of the set of bars on the left, and resistance to doxycycline, which is kind of the graph on the right. The orange bars here look at what proportion of the study population had Staph aureus in their nose at the time of study start. And it's about half, 45, 48%, and that's pretty typical for all of us. And then they looked again at 6 and 12 months, and those who were in the standard of care arm who didn't take any doxycycline were pretty much the same. There was no statistically significant difference there. And those in the Doxy PEP arm had decreased colonization. However, when we move to the resistance bars on the right, you can see that among those with Staph aureus in their nares, at 6 and 12 months had an increase in the proportion of isolates that actually had resistance to doxycycline. So this is something we're going to need to monitor going forward. This group also looked at kind of the gut resistome, resistance genes that are in all those bacteria that live in our gut and microbiome. So here we're looking at an analysis looking at tetracycline genes, kind of agnostic to pathogen, just looking at the genes. And we're looking at a comparison in purple of standard of care and in green of doxycycline PEP arm. And we're looking at baseline, day 0, and 6 months later. And you can see that there was an increase in tetracycline gene expression among those on doxycycline. Now, if we look at the graph on the right, we can see that, that the number of doses was correlated with the kind of quantity of tetracycline resistance expression. So the more doses of doxycycline a person reported taking, the higher their kind of tetracycline gene resistance is. So I think, you know, it's going to happen. We need to monitor going forward. What does this mean clinically? This group has also looked at the microbiome, and fortunately, at 6 months, did not see any differences in alpha diversity, beta diversity, or bacterial abundance. So as I said, it's going to be really important that we continue to monitor for antimicrobial resistance. We at CDC plan to do this, leveraging ongoing pathogen surveillance projects. In DSTDP, where I work, we have a number for gonorrhea, the GIST project, the SURGE project, EGIS, maybe some of you are involved with those, and the STD Surveillance Network, or SUN. We can look at gonorrhea resistance through this, and through SUN, we can look at uptake of Doxy PEP at the clinic level, as well as resistant infections through correlating with GIST. We plan to work with our colleagues in other parts of the agency where they monitor for other bacteria through the Active Bacterial Core Surveillance Project, Staph aureus, Strep pneumo, and others. We also plan to work with our colleagues in antimicrobial stewardship to look at how much antibiotics are being used and increased over time as we roll out Doxy PEP. But there's still a lot of questions to be asked. Questions regarding efficacy and use include questions about cisgender women and heterosexual men in other populations. Is it efficacious in those groups as well? How much does the timing of taking the pill matter? Do you have to take it right after sex? Is it okay to take it a day later? Maybe we should take it a day earlier or a couple hours before sex. How long should we recommend Doxy PEP for, both at the individual level, how long do you need to stay on it, and the population level? If this does drive down STD rates, at what kind of number needed to treat? If it gets so high, would we pull back Doxy PEP recommendations? What about treating our patients when they have an STI exposure? Right now, we recommend epi treatment if they know they've been exposed to syphilis or gonorrhea or chlamydia. But they also have Doxy PEP, and maybe they don't need it, but we need data on this to be able to move forward. There's also a number of questions regarding antimicrobial resistance, and I think Dr. Carolyn Deal is going to get into that a little bit more as well. So that is what I have for you today. I'm really excited to be here and share the Doxy PEP guidance with you. And now I'm really excited to share the stage with my colleague, Dr. Carolyn Deal, who is the branch chief for the Enterics and STI branch at the National Institutes for Allergy and Infectious Disease. Welcome to the stage, Dr. Deal.
Well, welcome everybody. It's a real pleasure to be here and to talk about this exciting area of research. I want to thank NCSD for inviting NIAID to attend. And I'd really like to this morning think about how we got here to being able to talk about Doxy PEP. And so what I'm going to start with is looking at some of the studies that led us to where we are, but also then what are some of the outstanding research questions that we hope some of you will take interest in and come to us with some investigator-initiated proposals. So NIAID supported the original study that found that doxycycline after unprotected sex significantly reduced STIs. This came about because doctors Connie Kellum and Annie Lukemeyer came to NIAID with a proposal that was an innovative idea, and it was supported through our peer review system. The results of that study is one of the things that changed the landscape. And Dr. Lukemeyer reported on this at AIDS 2020 and showed the reduction when used taking doxycycline within 72 hours, cut your risk of bacterial STIs. But even then, she pointed out that more research is needed on the long-term effects. So just to review the study, it was a randomized controlled trial where you had Doxy PEP in one arm and no PEP in the other. But the main objective was the reduction in STIs. So that was your primary endpoint. But what I want to point out, because I think that's where we get to some of our ongoing questions, are what was aimed to, which is the impact on antimicrobial resistance. And you can see here that just in the review of the data in the Kaplan-Meier curve, that you do see a reduction in incident STIs of 65%, but it did vary between gonorrhea, chlamydia, and syphilis. And I think the main thing here, they reported good adherence to the regimen of Doxy PEP. Now, you saw this just a minute ago with some of the data that Lindley put in. But what we're looking at here is what was the change in doxycycline resistant in the commensal bacteria, the commensal Neisseria. And you can see on the left that in the standard of care, you had, a little bit of a reduction, in the carriage rate, which you saw very little reduction in the Doxy PEP also. But the real difference was on the right-hand side in the increase in doxycycline resistant in the Doxy PEP arm. So this leads us to one of the ongoing questions: what is the effect on the commensal Neisseria in participants? I won't go over this in detail because Lindley just did, but I think one of the questions this points out is Staph aureus the appropriate kind of sentinel organism? Or should we be thinking about other ways to look at this? So currently, as an ongoing study in support of this idea, Dr. Lukemeyer and group are now looking at assessing the effect of Doxy PEP on selection of doxycycline resistance in Neisseria, staph, and in particular the commensal flora. And what she's seen is so far that you do see at baseline greater than 60% of the commensal Neisseria have doxycycline resistance. But you then see a reduction in the control arm. And so you're really looking at data that is not real conclusive, and there could be an imbalance in the two arms at baseline. So I think all of these lead us to, yes, this is a really good intervention, but there are some questions then for how we look at antibiotic resistance. So what are some of our next steps? We've pointed out, we know this has implications for antibiotic resistance, for Staph aureus, but I think even more critical is going to be what about the effect on the gut microbiome, the vaginal microbiome, and these are going to require long-term studies. There are two other studies that have been reported, the Doxy study in France, where they did see a reduction in STIs, similar to Drs. Kellum and Lukemeyer's study. And that data has been presented. It was just recently presented at the European Congress on Clinical Microbiology and Infectious Diseases, where Jean-Michel Molina reiterated that this data is now is finalized and has been submitted for publication. But then the other study out of Kenya did not show an effect in cisgender women. And they did hypothesize this is due to adherence. But I think there's a lot of questions about what's the effective way to measure adherence when you're talking about intermittent use of a drug. We know that you can take hair samples when you're using a drug continuously, but how do you do it when it's an intermittent use? So I think this is another of those outstanding research questions. And so going forward, one of the currently funded studies from NIAID is for Dr. Lukemeier and that group to look at more the gut microbiome. And so this is a much more complicated thing than looking at a sentinel organism. And that now you're looking at metagenomic sequencing of DNA on self-collected rectal swabs, and then they're stratified by their HIV status. And the team currently is looking at microbial diversity and looking at how the gut microbiome changes. And their initial conclusions, so they think maybe it doesn't change so much. But I think this is really interesting data, and it builds on the initial data that Lindley just showed. If you look in the top panel, you can see the expression of tetracycline-resistant gene by study arm at day 0 and month 6. And you can see in the blue, in the no PEP arm, that you really don't see a change in the expression of that gene. Whereas you look in green, you can see that the expression of the antimicrobial resistance does go up. I think what's going to be really interesting, though, is the bottom panel, and that in addition to looking at the tetracycline-resistant gene, you're looking at ones that confer resistance to other antibiotics, and it appears that there's really no change in those. So it really probably is specific, the Doxy effect on the tetracycline-resistant gene. So what are some of the outstanding questions? I think we're looking at clearly what's the ongoing effect on antimicrobial resistance, but is Staph aureus a good marker? And are there long-term effects on the gut and vaginal microbiome? What are the prospects for long-term use? As Lindley said, many of us have taken Doxy. Do patients get doxycycline fatigue after a while or can't tolerate the side effects? And then finally, there's a lot of more antibiotic distribution questions. How does the dose affect different things? Do we really have the right dosage? And then what is the best way to look at this in cisgendered women? So one of the other ongoing studies is from Dr. Susan Graham at the University of Washington, and she is looking at comparing what are two different interventions in MSM in Kenya. One is the WHO recommended periodic presumptive treatment versus Doxy PEP versus the standard of care, which is syndromic management. This study has just started, it's being funded by NIAID, and we really look forward to the results that this will come from this study over the next couple of years. And so I'll go back to those ongoing questions, and I hope that the questions you have today and some of the data that you've seen from both CDC and the new guidelines will encourage you all to submit investigator-initiated studies, because NIAID will be looking forward to hearing your ideas in the future and really look forward to research that can address some of these outstanding questions. So thank you very much. I want to acknowledge all the people at the STI team at NIAID and look forward to discussing all of this with you all. And so now it's time for our fireside chat. And I'd like to welcome back Dr. Lindley Barbie and Phil Chang to the stage.
So thank you both again for your wonderful presentations, and thank you for being here. So, and thank you for the audience for the questions that a couple of you submitted beforehand. We're going to go ahead and ask our panelists a couple questions here about Doxy PEP. So the first question I have for you, and I kind of alluded to this in the beginning, is how excited are you about Doxy PEP? Is this a game changer?
You want me to take that one?
Why not?
It really could be a game changer. I do think we have not had a biomedical intervention, and so this is really exciting, and especially the San Francisco data showing that population level incidence may be declining, and maybe we can get this on the national level. We don't have a vaccine yet for any of the 3 bacterial pathogens. We may be close with gonorrhea, but we've seen these are long-standing infections. We've had these bacteria since the beginning of humanity, pretty much, and not a lot of advancement. So this is the first real intervention that we have.
What do you think, Dr. Deal?
I agree. I mean, I think this is exciting. This came out of, really well-done research, which I think we all really like to build on. And I think this could be a real advance on our way that we move forward. It's a new tool in our toolbox for preventing STIs.
And you both raised a couple of questions. And I think really one of the biggest questions is about who is Doxy PEP right for? The studies pretty clearly show that MSM, cisgender MSM, and transgender women, benefit from Doxy PEP. Mm-hmm. The data, Dr. Barbie, that you presented on cisgender women is less strong. And in fact, there's even a study that did not show efficacy. So for the clinicians out there and the public health folks, if we have cisgender women who have had bacterial STIs, I'm thinking maybe about sex workers or people with multiple bacterial infections, how should we think about Doxy PEP with cisgender women and others who have a vagina?
Yeah, thanks for that question, Phil. I mean, I think the question, as both Dr. Deal and I said in our presentations, that is one of the big questions. Why did that study not show efficacy when we see it in men who have sex with men and transgender women? And, which we didn't present, but there are some PK studies that show that Doxy reaches acceptable levels in vaginal fluids. So why didn't it work? Was it really adherence? And I think that, Dr. Deal alluded to this. We don't know what the hair levels really mean, so I'm not sure we can put it all on adherence. And we certainly shouldn't put all of our eggs in one basket at this point. I think we need some more studies. We've seen with other infections and drugs that the vaginal environment can really change how people are susceptible to infections or to drug clearance of infections. And so I think we need a lot more data before we can make any recommendations there.
Dr. Deal, is this something that the NIH is looking to fund?
I think this is an area we think is definitely in need of research. I think there's a lot of, there's confounders. When you think about women, and you're talking about the vaginal microbiome, you as clinicians have all treated women with bacterial vaginosis. I think there's underlying questions about, the conditions of the participants as far as BV. There's also, when you think about it, in certain settings, is there a stigma to taking a drug in certain populations that may not be as relevant in other populations? So I think this is something that, yes, NIAID would welcome proposals in this area, and I think it's something that really needs some innovative thinking for how do we really address this question in a culturally appropriate manner that takes into account women's lives and how they live.
And I'll share my perspective too. I think with my physician hat on, it becomes sort of a case-by-case basis for cisgender women. Certainly if I have someone in front of me that's a sex worker and I think at really high risk of bacterial STIs, someone that maybe has had multiple infections, I'm probably going to prescribe it based on what we know. And the basic science studies show, right, that there should be good penetration of doxycycline in the tissues. And I think, Dr. Barbie, per your presentation, we believe that the DPEP Kenyan study failed because of low adherence. So let's switch gears. The other big question that we have is about antimicrobial resistance, and you both sort of touched on this. I mean, how big of a deal is that? How much should that factor into or not when we think about prescribing Doxy PEP? What do you think, Dr. Deal?
Well, I have to say, I know within the STI community, everyone's really excited about that. If you look across the broader infectious disease community, I think this is still a discussion point. And we hear from people, on both ends of the spectrum. And so I think this is where research will really help to either say, yes, we need to be careful, or no, this isn't a concern, or maybe it's appropriate in certain instances, Phil, like you just said, on a case-by-case basis. But this is certainly something that is still of active discussion, I think, within the antimicrobial resistance community.
And how do you think about this, Dr. Barbie? You mentioned sort of a lot of the different surveillance studies that are happening. I mean, if we use more doxycycline, we're probably going to see some resistance, correct? But is there a threshold, or how concerned are you about this?
I really think it's a balance, right? We have really high rates of STIs right now, and antimicrobial resistance is probably going to happen. And that's part of the population as well, right? Finding people who are most at risk of STIs, so you get that number needed to treat low enough where you're decreasing STIs, but not increasing as much the antimicrobial resistance. And finding that right balance is going to be hard, but we're working on it.
One thing I think, too, that we have to consider as a field is that we overuse a lot of antibiotics for many other things, and even not in human use, right, for animal use, animal feed. So I think if we really want to think about antimicrobial resistance, it's not just Doxy PEP, it's all the other antibiotics that we're using for everything else, frankly.
Absolutely, and it's not a question of Doxy PEP versus no antibiotics. There's a lot of treatment for STIs as well.
And could I add in that area? I think that opens up another area of research and product development that may seem tangential, but it's looking at diagnostics in a use, because you think of many parts of the world, they do syndromic management for STIs. If you can move to etiologic diagnosis, you immediately potentially have the impact of more accurate antibiotic or not prescribing. And so I think when we think about that, there's also other technologies that will help address this issue by more like, say, point-of-care diagnostics, that type of thing.
And one last question I wanted to ask is about equity when it comes to Doxy PEP. I think one thing that we've seen related to HIV for PrEP is that we see pretty significant racial and ethnic disparities, and we've seen those for the last decade of PrEP. How should we be thinking about this as we roll out Doxy PEP, and how to minimize disparities, especially racial and ethnic disparities?
Absolutely. That is one of our big concerns at CDC, is how we're going to roll this out equitably. And it's going to rely on all of you to really take this message home and make sure that everyone has access to it in your clinics, health officers talking to all the providers in your states, letting them know that this is available and should be prescribed for individuals who meet the criteria.
And our time is winding down here. Any final thoughts to the audience here about Doxy PEP, or anything else you want to share? Dr. Deal, why don't you go first?
I think this is an exciting time for STI, prevention. As Lindley alluded to, I think there's things that are coming through the research pipeline that could change our future in a positive way. We're looking at supporting vaccines for prevention of bacterial STIs. There's a lot of work in new therapeutics and diagnostics. So I think this is just the start of a new toolbox that we hope will really help address this issue in the future. And we look forward and encourage all of you to think about areas of research and where you can have an impact with the studies you propose?
I mean, I think that's right. We're at a really unique crossroads right now in the STI field. Our syphilis rates are higher than they've been since the 1950s, and we finally have a good biomedical prevention. And so I'm really optimistic that the next 5 to 10 years, we're going to see some major changes in this field. And for all of you who do this work every day, keep up the good work. We're so grateful for you.
Wonderful. Thank you again, both of you, for joining us, and thank you to the CDC and the NIH in general for all that you do. Let's give them one more round of applause here.
Thank you. Thank you.
Please welcome, from PrEP for All, Jeremiah Johnson.
Great. All right, let's sit down. Hello, STI Engage. Thank you for being here. You made it to the last panel, and like Vanessa Williams, we are saving the best for last, of course. My name is Jeremiah Johnson. I'm the Executive Director of PrEP for All, and I'm so grateful to NCSD for putting on this great conference and for inviting us to be part of this panel. We have some great experts here who are going to continue the great conversation on Doxy PEP and the promise, and really talking about it from a perspective on what have we learned. And so, I think David and Elizabeth and others invited me specifically because we are calling for a national PrEP program, and we have so many inequities still going on in terms of PrEP. And there's so much that we need to learn from and talk about what have we learned and how do we do better with Doxy PEP and all other interventions for communities that haven't been able to get access at this point. And so we're going to carry forward that conversation here with all of you this afternoon. Everyone is going to introduce themselves real quick. And I also want you to just briefly say why you are passionate about STIs and Doxy PEP. And we'll start with you, DeMarc.
Thank you, Jeremiah, and good afternoon, everyone. My name is Dr. DeMarc Hickson, and I am the Executive Director of Us Helping Us People Into Living. We are a community-based nonprofit organization headquartered here in Washington, D.C. And I'm excited about Doxy PEP because as we see in our work, we have about a 16% prevalence rate of bacterial STIs, but we also see repeat STIs, so STI repeaters, which is about 8% within our clientele. So I'm excited to see the work ahead. We partner with several agencies during DC Black Pride, for example, which was last weekend, and we gave out 63 doses of Doxy PEP. So really seeing the uptake within community as well is what excites me.
Wonderful. Karen Surita.
Yes. Hi, everyone. I'm Karen Surita, and I am the STD Public Health Follow-Up Manager with the Texas Department of State Health Services. And so I'm passionate about STIs because it's such an exciting field. I mean, you're always challenged with something. You go into the office, there's something new that pops up, you have to address it, but you also always are thinking about 10 steps ahead of. And I'm excited about Doxy PEP because it is a game changer for people. It gives people options, and I think it also allows people to make decisions for themselves and their sexual health.
Wonderful. And Deja Moore, who is from the absolute best state in all of the states, Colorado. Please introduce yourself.
Hey everyone, my name is Deja Moore. I am an Afro-Hispanic woman of trans experience in Colorado. I also work at the Colorado Department of Public Health and Environment as our Comprehensive Sex Education Grant Program manager effective July 1st. But I will say for me, this is really an opportunity with Doxy PEP to really promote gender inclusion and affirmation, especially for us women of trans experience, because we are so disproportionately impacted.
Wonderful. And he's back again, this time in panelist form. Dr. Philip Chan, would you like to introduce yourself again real quick?
Yeah, so thank you. Back for more for Doxy PEP. So I serve as one of the consultant medical directors for the Rhode Island Department of Health, and I think that Tom Bertrand, the chief, is here for the Center for HIV STIs. And I'm here today, especially with my clinical hat on, where I serve as a primary care physician at Open Door Health, the state's only LGBTQ health center. And I'm super excited about Doxy PEP. I do believe that sexual health in general and just healthcare in general is really a human right, and everyone deserves it. And we've started rolling out Doxy PEP in our clinic and have already observed some clinic-wide trends just in STI decreases. And I think that slide that Dr. Barbie showed about San Francisco and what's happening there with widespread Doxy PEP is really so exciting. So I really do feel like Doxy PEP is a game changer for bacterial STIs.
Amazing. Thank you all for being here to share your expertise and your perspectives. And I think this is going to be a great conversation for the next 35 minutes and 2 seconds. So our opening question is, and I would love all of your perspectives on this one. As you were just talking about, Dr. Chan, we've been seeing increasing bacterial STI rates for years. Do we think that this is going to make a difference? You've started to allude to this. Do we think people want to take it? And I'm also curious, do we think that prescribers are going to want to prescribe it? So I guess maybe we could start here and go down the line.
Oh, I thought you were going with Dr. Chan first.
Oh, I did. That was a bit of a bait and switch. Sorry.
Yeah. First, I'll start with community response, and that there's a demand for Doxy PEP. I'll just give 2 brief examples. The first is, during DC Black Pride, we partnered with Deviant Society. And during the panel, very much like this, I asked the question saying that if I had Doxy PEP on me right now, how many of you all would take Doxy PEP? And nearly everybody in the room raised their hand. And similarly, we partnered with Stonewall Kickball, which is an LGBT kickball league here in DC. And we had our mobile unit we pulled up to the game, and we had a line of about 75 people. And someone was like, oh, I'm not wanting to get tested. I'm just going to come up and get my Doxy PEP, right? So there is that demand. And I think just from a clinician, I'm not a MD, PhD, so I'm going to give that caveat. But our providers that are in our clinic or our health and wellness suite, we try to stay away from the word clinic, they prescribe Doxy PEP on a regular basis, but they've instituted where you have to be engaged in sexual health. So they're just not going to keep sending out medications. We know that physicians can now, pharmacies will now deliver medications and you don't have to come in, but our providers require that you come in and be engaged.
Amazing. Karen?
I think the short answer is yes. I think we also, as working within a state health department, is that we also need to make sure that we're looking at the populations being most impacted. And I think it's also taking a look at, based on the recommendations, which of those populations are most impacted? Do we have the information that we're able to share with our leadership in terms of saying, yes, this is an effective intervention, the science proves it, but also people who are not embedded in this field that are running some of our state and local health departments, we also need to be able to communicate that effectiveness, and oftentimes they want to see numbers, they want to see which communities are impacted the most, and sometimes with the challenges of having increases in syphilis, we may not be able to ascertain those risks from the data that we have for chlamydia and gonorrhea, but I definitely think we can sell this to our leadership when it comes to syphilis infections and decreases as people uptake Doxy PEP.
Great. Deja?
Yeah, I really believe that this is an opportunity, to really prevent STIs. Just given like the efficacy and efficiency, I think with Doxy PEP, it's just how we market it is really important. In Colorado, I'm serving on our Doxy PEP steering committee, which is a collaborative approach with our Denver Metro STI Coalition and the 5280 Fast Track Cities organization. And just being able to be a part of that opportunity as a woman of trans experience to really update our guidelines, because one, we were just singled out as like just trans women that were just MSM. And I had to come in and say, yo, I am a woman of trans experience. How do we lay this out? And so it's just in the language, how we market it. As long as we continue to say MSM that we are, I think that's a major drawback to our community. We really have to promote, I think, women empowerment and really make sure our language is inclusive. As we see too with the CDC guidelines, really ensuring that not only assigned male at birth folks, but also assigned female at birth folks are included in the messaging. And even though that the studies are still kind of being determined, I think we have to be proactive with our approaches, because being proactive is really going to support the sexual pleasure and opportunity for folks.
Wonderful. Yes, yes, yes. Applaud, applaud. And Dr. Chan.
Yeah, I'll make 2 quick points. You know, in general, I'm reminded that a lot of people are a little bit less concerned about bacterial STIs. I think that generally people are fearful about HIV. I think that that sort of spurned a lot of HIV PrEP uptake. But with bacterial STIs, you know, a lot of times I get a shrug, you know, and, oh, another chlamydia case, you know, give me my 7-day course of doxycycline and, you know, and that will be it. So I think we have to do a little bit more education and awareness just about the importance of other bacterial STIs and other STIs in general. And the second thing that I'm hopeful about, right, when HIV PrEP came out, it was this antiretroviral, and no one except HIV physicians had a lot of experience with it. Well, doxycycline's pretty common, right? How many people have taken doxycycline before? You know, I took it, you know, for acne once upon a time. So it's a very common medication. Primary care docs should be aware about it. I think the other piece of good news is that it's generic, right? So a lot of generic formulations, we don't have to deal with all the insurance stuff about it. So I'm optimistic, hopefully, in primary care settings, that there'll be a lot more acceptability by primary care physicians and other medical providers to prescribe it for this purpose.
Amazing. So enthusiasm across the board. This is exciting, and we're very hopeful about it. Deja, you started to jump into the next question a bit as well, because the big announcement, and we talked about it here earlier today, is the guidelines finally coming out yesterday. And wanted to get your initial take on the guidelines, where it's at. Are there any considerations that we need to have about these guidelines, other guidelines that we need to be thinking about, you know, in terms of what populations that it's geared to in particular? We had a few pre-submitted audience questions. I know there was a question about should we be marketing this to straight men as well in order to talk about this. So curious about your take, and we can just, whoever wants to jump in to start.
Yeah, I guess for me, I mean, if you're engaging in sex and you are not using protection, like, we need to market this as a multi-pronged approach, really, as prevention, regardless of who you are. Yeah, and I think, you know, as long as we continue to have these barriers set in place of who can and who can't, you know, we're really missing out on certain folks at the table. And, you know, for the longest time, too, even just with women across the board, like, I think we've just been excluded, you know, from a lot of these pieces. And so not only should the onus be on us, but we need to encompass our men at the table, too, because, again, we're all of us as a community. We need to be in this fight together. And I hope one day we can really promote sex positivity in a good light. Yes.
Wonderful. Does someone else want to answer that as well?
I mean, I would echo Deja. I think Deja always brings up really good points. I also think if we're going to continue to try to remove stigma, then we can't have these types of like recommendations that are strictly solely on only certain populations. I think we also need to expand research to include women in part of the research, because if we look at congenital syphilis, also we know that it does also include a partner. Another partner, and usually those are male partners, and they may not share their risk. They may not also have sex with men. So we do need to include them and make sure that clinicians are taking an adequate risk assessment, and then also promoting this as an intervention for them.
Wonderful.
I'll just add, as a, you know, as a primary care physician, I am prescribing it to cisgender women. I know that the providers who work with me are as well. I think the CDC sometimes gets in a tough place because they have to focus on the evidence. And unfortunately, the evidence really is clear about cisgender, MSM, and transgender women. Yeah. But the data also shows from a basic science perspective that, again, that there should be equivalent concentrations, you know, in cervical tissue in the vagina that protects against some of these other bacterial STIs. So at least as a clinician, I'm doing it. I think most of the clinicians in the sexual health field are also doing it. But I think per the NIH and Dr. Deal, like that should be one of the urgent, topmost priorities to look at that.
Absolutely.
Yeah, and I'm glad that you mentioned that, Dr. Chan, and that you're actually prescribing it, because as I was sitting here just thinking about it, this is yet another biomedical intervention that could be stigmatized again for sexual minority men and transgender women. We just came off of Mpox that was largely targeted to sexual minority men and trans women. We know the stigma, or at least the piece around PrEP, especially with the low uptake among cisgender women, where they're always saying, oh, we just thought that this HIV PrEP was for gay men, right? So again, this is yet another piece, as you were mentioning, Deja, that will be targeted and stigmatized. And so if we can get out in front of it early, that I think that it will be acceptable and not as stigmatized as other biomedical interventions have.
Right, and I was gonna say too, I mean, we have, I don't know if many folks have heard of PrEP, the 211, but I mean, is that possible even with Doxy PEP as a 211, so that way we can kind of kind of be ahead of it,
Yeah, I think it's an interesting, there are different hats to have on. From a guidelines perspective and a regulatory body, you have to follow certain evidence, but that doesn't mean that we can't widely be talking about this with communities. And actually, when we get hesitant, that's with PrEP where we have seen some of those challenges before in terms of sort of equitable knowledge that we're still dealing with.
And I'll just add too, the doxycycline has been studied as post-exposure prophylaxis. So there's one very early study that looked at doxy as PrEP among a couple dozen people. So it's not recommended to take one pill once a day. And I think that this is actually a good thing. We spend a lot of time talking about antimicrobial resistance. I'm optimistic that using it as post-exposure prophylaxis, so periodically, will actually minimize the amount of antimicrobial resistance that we see. So I think that it's a good balance between STI protection as well as minimizing both long-term side effects from taking a pill every day and minimizing antimicrobial resistance as well.
Sounds great. So, we talk a bit about syndemics at this conference and a lot of conferences. And a lot of times when we're trying to scale up a new intervention, we're trying to also access those populations around PrEP and testing and Mpox and all sorts of different interventions. So how do we, in terms of implementation, focus on a syndemic approach? How do we build this into existing programs with existing funding? Where does DIS come in? How do we have sort of an expectation that this will be part of that full toolbox that we've been talking about here? And Karen, I'm going to turn to you first because I think you have an interesting perspective on this.
Yeah, the approach that we need to take with anything when we're given the tools and we think about the implementation and how it will impact the communities that we serve and that are most impacted is that we need to look at any current strategies that we have. And whether it's a 1-year strategy or a 5-year strategy, we really need to think at what are those points of intervention that will be most impactful. How do we work with our HIV prevention partners, our substance use partners, mental health partners, or any other partners that truly are part of the conversation and need to be brought into the actual activities? How do we prepare them with the information that they will need and that they can also share with us about working with populations that, as we all know, we're stretched very thin? And how do we work with those populations in terms of where we can be most impactful? So I think having that strategy available to us is essential. It keeps us going towards a path, moving forward. And also, we have the ability to look at what are our outcomes, where are we seeing the differences and changes in terms of the outcomes related to the populations that are being impacted by STIs. And especially, I think, for us, we will look closely at syphilis rates or morbidities across the board and uptake. I think we can also learn a lot about campaigns that are already in play and what HIV prevention has done in terms of those campaigns. And then, but most importantly, I think also asking community, because there is this uptake already. So we don't have all the answers in state and local government. Community has a lot of answers, and we need to have those conversations with them. Sometimes we're not the best to facilitate that, And that's why we look to partners who have the ability to do that, and they already have that built-in trust.
Amazing. Yeah, I think when we were preparing for this panel, we were talking about how this is an intervention that community has been calling for and championing long before this. So we need to honor, sort of that community perspective, that lived experience in terms of talking about equitable access and meeting people where they're at. And I'll speak for PrEP for All, as we've been calling for a national PrEP program for un- and underinsured populations. We believe that that infrastructure should be able to help scale up equitable access to Doxy PEP, to Mpox. For HIV negative individuals, we need better infrastructure that can reach everybody on all of those at the same time. Any other thoughts on that question from anyone?
Yeah, I'll just say, we really need to start trusting our communities and our champions, like you were alluding to. I think, we have promotoras in the community. We need to make sure that they have this information, that they can educate those that they're working with. We have community groups and champions also that are leading different support groups. I think we need to enable them to have access to this information and to spread the knowledge and to understand that it's safe. This is, a great measure, and I think if we kind of don't share the information with others, then we're really missing the mark. And then the marketing materials too, who you're marketing to. Have champions start those campaigns and have them share their stories. I think that's a great way also that folks can really understand that, yes, this is a safe measure, and I see myself being a part of this.
Amazing.
And I would say that also it has to be a multi-layered approach. I mean, the majority of the participants here are also DIS, and so we have to empower DIS, and because DIS are reaching those individuals who this intervention would be most appropriate for oftentimes, and they may not be actively engaged in a healthcare setting or prevention efforts already. So I think is ensuring that DIS have the tools they need to promote this intervention, to ensure that we're doing a full comprehensive screening with clinicians and clinicians feel comfortable, especially in communities where there is a provider desert. It's oftentimes just for routine health care. And so adding this onto their plate is also important so that they are offering, like Dr. Chan said, offering the intervention and prescribing Doxy.
Absolutely. Yeah, to your point, Deja, I was talking backstage with Elizabeth from NCSD. We were talking about that we need really accessible messaging for people, not just a standard public health campaign too. I think that there's something about, maybe CDC is not the one to fund that, particularly in an election year. But who else is going to help fund campaigns that are really sex positive, that really speak to communities that don't get that messaging? And curious about what could happen with that as well. So another question in terms of implementation, and I'll turn to you, Dr. Chan, for this one, is how you've talked a bit for yourself how this is being implemented by physicians. What else needs to happen to facilitate this even further for medical professionals? Do we have adequate, prepared clinical staff? And what are the interventions that we need to do around that?
Yeah, so I think we do. Again, doxycycline has been out for a while. I think that a lot of providers, clinical providers, are comfortable with doxycycline in general. When I think about this from a systems perspective, I think about, you asked the question, where are the majority of your bacterial STIs being diagnosed? So one thing that we've done at our health department, we've pulled the top 10 places, and we have a list of where all the bacterial STIs are being diagnosed. So I'm thinking about, urgent care centers. I'm thinking about STI clinics. I'm thinking about HIV clinics. I'm thinking about student health centers. And I think in thinking about the health departments, right, there's also the DIS, right, and partner notification services. I definitely think that as part of routine counseling that we should start to weave in some Doxy PEP. I mean, I'm sure from some of you that have done, contact tracing, you do see the same people over and over, some of them over and over, for chlamydia, gonorrhea, and syphilis. And I think that this is a great opportunity to start to educate those folks and get them in to try to interrupt that cycle and interrupt transmission in the community. So that's where I would sort of start in thinking about the early stages of Doxy PEP implementation.
Amazing. And curious if anyone has any thoughts about equity in terms of, because we know for PrEP that oftentimes a prescriber will withhold PrEP from people of color, but prescribe it to a white patient. Because of perceptions of, how responsible that person is going to be. And curious, how do we counteract that? How do we get ahead of that? I don't know if anyone has any thoughts on that.
I mean, straight up, we need to address systemic racism. That's one. Oppression and biases. We have to call it out for what it is. I'm a huge proponent of people understanding the privileges that they have and not trying to be a barrier. As long as we continue to be barriers to folks, folks are not going to be able to have access, and that's a major barrier. And I think too, we need to meet people where they are. So if it's bathhouses, if it's, where sex work is happening, go to those areas. I think hitting up Grindr, Bumble, all of these dating sites, these need to be opportunities or points of access where folks are aware that this is available.
Absolutely.
Yeah, definitely agree, Deja. And just thinking about the structural racism and discrimination that exists and how it pushes communities, especially those of color, and particularly Black communities, which are oftentimes the last one to receive any information or biomedical discoveries, and that we have to push and advocate for the communities that we represent and that we have the privilege to serve, because we saw this with COVID, right? We saw the low uptake and more deaths among Black communities. And for myself and fellow colleagues, we weren't going to allow that to happen, for example, with Mpox. So we were yelling at health departments and saying, come hold a clinic here. This is how you'll reach the Black folks or others, because we saw it nationally, right? When there were Mpox vaccination clinics, even in racial minority communities, there were white gay men who were in line first, right? And so I think what this saying piece is that we're just being proactive now, because we don't want what happened with PrEP, and we see in 12 years later the low uptake in Black communities. And so I think we just have to, again, for us, by us, and push to make sure that we are represented and engaged at the different stages when biomedical discoveries like this come out.
Absolutely. Yeah, I think one of the frustrating conversations in HIV we have all the time is people talking about people being hard to reach. And it's like, they are not hard to reach. They are getting services from somewhere.
Come on.
If a bathhouse, that's a service. So,
the strip clubs too, I'm like, we gotta meet people.
I know in terms of a national PrEP program, we keep talking about, how are we leveraging telehealth, so that people see it accessible. Dr. Chen, you were talking about this is a super cheap generic intervention, so we don't have some of the hurdles and the challenges that we've seen, like with brand name PrEP medications, which have been so expensive. And also going to those other maybe non-clinical spaces, whether it's through pop-up clinics, whether it's through creating networks. We talk about a hub and spokes approach to connecting clinical hubs to different non-clinical spaces in the community. And I think we see that as being a pathway here as well, meet people where they're at.
And I think to address, in part, the equity issue, we also have to address the cost issue. And this is what I love about the PrEP for All, is you have to remember, right, the cost of the medication, and oral PrEP has been expensive. Thankfully, that's not something we necessarily with doxycycline, although even doxycycline for a month's supply is $25 to $50, which can be cost prohibitive. Mm-hmm. When someone's on doxycycline, the recommendations are to follow up every 3 to 6 months. There's no special labs that you have to get done, but it is recommended to get all the other STI testing, as Dr. Barbie mentioned. And for those of you that have been doing this, you know that those other STI testings, especially when you're thinking about extragenital sites, it becomes expensive. At our institution, it's about $100 per test per site. So that easily becomes $500, $1,000 per lab visit. And then there's also the clinic visit. So even as we talk about addressing equity, we have to fix the cost issues and thinking about how to address all these different buckets of costs, which also come from different places. You have the pharma company for the cost of the medication, the lab, which is a separate organization, is billing you for the lab costs, and then the clinic as well. So we have to figure out how to just make it more accessible in order to achieve equity, in my opinion.
Absolutely, absolutely. So that brings up the question of funding a bit here, actually. So who's paying for this? If people are insured, presumably they'll have a pathway around that, but for un- and underinsured populations, for building these networks, building these campaigns. What do we need? And Karen, not to put you on the spot, but I feel like you might have some immediate thoughts on that.
Well, I think we have to look at what our funding will allow us to do. And I will say, you know, when the treatment guidelines came out yesterday, the CDC, it's something that I asked for during this meeting, but they did send out a letter, right? A letter to grantees saying, this is how you can use the funding. And I think that's important to have when we go to our leadership and say, okay, we're going to allocate additional money for medications, but not only medications that we can purchase at the 340B pricing and made available in our local health departments or directly funded programs, or whether it's indirect activities or in-kind services, but also ensuring that we have the funds set aside for those additional testing, because that's important, that's key, right? Screening and then testing. I think that we can also go to our state legislators, because we do receive general revenue funds, but make that argument. And again, like I said earlier, they definitely love data, but having that available to us to make that argument to why we need additional funding and what's the return on the investment. They want to see those numbers go down. They want to see less questioning from our state reps and our national reps when it comes to the increases in syphilis. And then also leveraging what we know in terms of how we've asked for funding for congenital syphilis. Because oftentimes the argument becomes that we don't want to see babies impacted.
Yeah.
And so if we can use that information to help with preparing these requests, then I think that's the approach that we need to take. But definitely it's making sure that the funding is put into direct client services.
Absolutely. So that flexibility in funding that we're hearing about, you know, talking to CDC about their state funding pathways,
Yes.
that's going to be essential, because just guidelines aren't going to be enough in terms of implementation.
Exactly.
Very important, very important. We have 9 minutes and 2 seconds left, so let's dive in a little bit more into the equity question and any other considerations that we haven't talked about yet, because we know after over a decade of PrEP that of the 1.2 million individuals who are most in need of access in the US, preliminary 2022 data estimated that 94% of white individuals had received a prescription, only 13% of Black individuals, only 24% of Latinx individuals. For cisgender women, it was only about 10%. And the data on transgender and gender diverse, we don't have enough data in terms of all of that. It would be amazing if we could break that cycle. So what else do we need to consider to get us there? And what can we be doing differently in terms of equity? It's a heavy question.
Yeah, it is a very heavy question. I think in minority communities or communities of color, we need to just start talking openly about sex.
Yes.
When we think about Black communities, and I don't know why I keep talking about Black communities, maybe I'm Black, but if you couldn't tell. But when we think about the Black community, we are the most conservative when it comes to talking about sex. So we say we're progressive, but not when it comes to sex, right? And so I'm a product of a sex education teacher, so we always had the brown bag of condoms from the health department at home. And so really just normalizing that conversation and just, again, being able to educate communities about all of the tools in the toolbox, as been said, and just really just continuing to work and just saying that these things aren't over, right? And so we don't want to see the babies impacted. We also don't want to keep just people just coming in, oh, I got the sisters again, the gonorrhea and chlamydia. And I think it's, as part of this conversation around sex, just talking about pleasure. So I was in a session yesterday where that really piqued my interest because we don't talk about that. Right, and I think as a numbers person, just always thinking like the prevalence rates I first mentioned at the very start of this session. So, yeah, we got some more work to do.
Yeah, absolutely. Any other thoughts on that?
Yeah, I was gonna say we gotta have those conversations. You know, being Afro-Hispanic too in the Latinx and Hispanic community also, like Catholicism is very huge too, and so we really have to start breaking down the stigma, with folks engaging in sex or, pleasure too. Like, yes, have fun, have pleasure, you know what I mean? And understand, like, how do you protect yourself? What are the tools available? You alluded to cost. That's a major thing as well. And I think just making sure that we have stories from people, that like, hey, I've been on this, I've got it, it worked for me, like it's gonna be okay for you. Like all of these different things will help de-silo it.
And I'll just add, I think that we have to really start to think about integrating some of this into primary care. We have to go to where communities of color tend to get their primary care. I'm thinking, at least in our state, a lot of FQHCs, and we have to educate not just the community, but also the providers as well about this. And I think FQHCs are often a lost opportunity.
Absolutely. And I think just another point, we need good data on who's accessing Doxy PEP also. Like, what's the strategy to track how our success is going and make sure that if there are inequities, we're catching it soon and being able to lift that up as well for all populations. Let's see here. So I think there's been a lot of conversation today about antimicrobial resistance, and that we feel confident that in the short term, probably not a lot of consequences, but there's a lot of tracking and making sure. From an implementation standpoint and from an equity standpoint, how should we be talking about that? Do we need to be more cautious? Do we need to really be trying to get this out there? There's sort of a natural tension there between those sorts of narratives. And I know with PrEP, when we first started implementing it, it was this sort of tense, maybe we shouldn't give this to everybody narrative. And that did lead to some challenges with scaling up. How do we balance that here?
We got to be truthful. I think even with PrEP, I was thinking, I don't know if many of you all saw, there was even some lawsuits happening, just on TV. I think we really have to be critical about talking about all the side effects, letting folks know all of the information at hand, and really showing, I think, the more positives than the negatives that show, and just showing again too the safety behind it. I know you're alluding to just the microbiome and all of that as well, but I think folks have to know that information at hand, and then they can make the best decision for themselves.
Great. And I'll just add, I got to tell you, when I have that patient in front of me, the last thing I'm thinking about is antimicrobial resistance. I think from the systems level and the public health level, sure, it's something we have to watch, it's something we have to worry about. And I am worried about it. I'm an infectious disease doc by training. But when I'm thinking about that patient in front of me, I'm thinking about what's best for them, how I can help them. And antimicrobial resistance is really a distant thought in terms of risks. I am much more concerned about some of the side effects. Side effects are minimal, but some of the people who do get them, they can occasionally be serious. So that's the discussion that I have with them in terms of risks and benefits. The fact that sometimes these medications do have significant side effects, although they tend to be rare.
Yeah, and I definitely don't think that community is thinking about resistance. Again, they hear of this strategy and they are demanding it. So I think that's something else that, yes, is a piece that we have to keep in the back of our minds, but it's also being able to meet the demand that the community has for it.
Yeah, I would agree with that. I think we need to push prescribing Doxy PEP out. I think that we can monitor it from our agencies in terms of state and local health departments, but I don't think that that's the immediate concern of individuals who are wanting to access the medication or the intervention, and we need to listen to that. And I think that we can do the monitoring in terms of working with our national partners, as during the previous presentation presented that slide deck that had all those that three-pronged approach. I think that's important to have for us, but I think it's important to push the opportunities and the access points for prescribing Doxy PEP.
Absolutely, absolutely. I couldn't agree more. I think it's very important to get this to people, particularly when we have the problem with syphilis that we do, and a bacillin shortage. I wonder how that's driving antimicrobial resistance personally. So before I get to our last lightning round of your key takeaways, in the spirit of a syndemic approach, we're going to put a slide up right now with a QR code. This is actually related to Mpox, and it's a letter coming from PrEP for All and a team out of UCLA, a project Stick It In. And it's a sign-on letter for individuals and organizations. Yeah, it's a great name. And so we are looking for people to sign on. This is a letter to the federal government on some key recommendations for addressing mpox coming up, including concerns about access for uninsured populations around the vaccine, getting recommendations and research and modeling around boosters, because we don't know enough about that yet. Talking about being able to detect clade 1 should it enter and being test ready for that, and just making sure that we have an equitable access approach to TPOXX going forward as well. So as you're scanning that, I'm going to turn, and we've got just a few seconds left. Go down the line. What are your top 1 or 2 things that you hope people take away from your comments today?
First, again, pushing Doxy PEP, and I think getting an answer to one of the statements that you made earlier about the marketing for this, right? And so really making sure that the messaging is right, because we saw what happened with mpox.
Yeah, totally.
I would say, because I have the opportunity to work with several disease intervention specialists, is remove yourself from being a barrier. Make sure that you have the information that you need so that you're recommending this as an opportunity for people to continue to reduce their risk for acquiring an STI. I think that's important.
Amazing. Deja.
Yeah, I'll just say, at least for our physicians, please have gender inclusive language when you're working with your patients. That's number 1. I think number 2, really try to work with different stakeholders beyond just yourselves as a community to invite people to spread that education and awareness.
Amazing. And Dr. Chan.
I'll say gender inclusive and also in Spanish and other languages as well. But I'm very excited. I do think that Doxy PEP is a game changer. I think it's important to start to think about ways that you can weave it in to whatever you're doing, wherever you are. And there's lots of resources out there. I know the CDC is very willing to questions and queries and presentations about this. There's a lot of my ID colleagues who are also doing presentations and training sessions on this as well. So the resources are here, and there'll be more and more as time moves on.
Amazing. So many great points, so much wisdom. Thank you so much for being here and being a part of this panel. And have a great end to your conference. Thank you, everybody. We'll go this way.
Please welcome back to the stage NCSD Executive Director, David Harvey.
Don't go anywhere, beautiful people. This is such a sad moment. What an intense, incredible few days. I want to thank some people. And then I want to officially close this year's meeting. Unknown to all of you, during this entire conference, there has been a raging party going on in the green room. The former DSTDP directors, our NIH friends and CDC colleagues, and all the speakers. We have quite a setup back here. Drinks, monitors. It's been a lot of fun. And in that vein, there is a ton of people who have put this conference on behind the scenes. There are 2 very special companies that we work with, Pre-Con and Event Power. I'm not going to get everybody's names right, but Event Power are the folks who run our registration process. Mike, that is the smoothest registration process I have ever seen. Would you agree with me? Maria and Crystal. Only 2 people ran that whole thing. The Pre-Con team, boy, do they give us a hard time. We love them dearly. Rick, Amanda, Jen, Millie, Josiah, Paulini, Justin. These are people who are in the back of the room and in the green room helping to manage this whole meeting. A huge round of applause for these folks. Jen, we love you. Jen is the disciplinarian. and we're all very scared of her. The NCSD board and our board planning committee, where are you? Just stand for a second once again to be recognized. This meeting would not be possible without all of you. I want to do a special thank you to everyone who is here from DSTDP at CDC. Can you please stand? The project officers, the leadership, the branch chiefs, your presence here and your permission for allowing CDC staff. There's lots of rules and regulations that go into how many CDC staff get to attend conferences, but CDC has been here in force, and we are really grateful. It has led to really important discussions at this meeting. Thank you for being here. Can you please stand, CDC folks? Thank you for joining us. It's developing relationships. That is how we get this work done. And of course, as we know, as you heard Admiral Levine speak, we have had a whole of government response now to STIs, long overdue and very, very much welcomed. So we have NIH staff here, of course, Carolyn Deal, and we have HHS staff out of the Assistant Secretary for Health's office. I don't know if they're still with us, but we really appreciate you joining us for this meeting. There is really, despite some of the heaviness of some of our discussions, there is reason to be hopeful. So thank you once again for coming. 1 in 4 of you presented at this conference. That's an amazing statistic. Thank you for lending your expertise, submitting abstracts, and being speakers. This is the best content we have ever had as a conference. You can applaud. The NCSD team. NCSD team, please join me on stage. They are going to enter from the back, from the green room. This is the most wonderful group of people you could ever work with. You all already know that because you have been telling me about this all week. Thank you for all of the hard work that you did to put this meeting on. And joining us virtually, there is other staff that work for NCSD across the country who are not here with us in person. Marlena Kincaid in Delaware, Charlie Rabins in Miami, Diana Rono in Idaho, Aaron Senato in Ohio, Jeremy Nichols in Houston. Forrest Wild is where? Minneapolis. Just amazing. Thank you all who you are online watching this session and been supporting this meeting. Thank you very much. We left New Orleans. How many of you were in New Orleans? That was quite the party. I didn't know quite what was going to take place. That was quite a party. And it was not cheap. But we recovered from that. New Orleans was amazing. It was the first time we had come together post-pandemic, and just being together in person made the whole meeting. We left that conference really on a high note. And to state the obvious, what we thought was going to happen did not happen. 2 weeks after that meeting ended, the DIS rescission happened. And that is heavy on our hearts at this moment, because it means that many of you are struggling across this country with how you're going to protect your staff, DIS, and others over the course of this next year. NCSD is never going to stop fighting for you to try to help alleviate this situation. It's our top priority over the next year and years to come. We started this conference with a message around social movements, and we quoted the late Congressman John Lewis. It just seems really appropriate to cite him again as we close out this meeting. And there is a wonderful statement. He gave so many wonderful speeches. But this statement is really meaningful, I think, to all of us at this moment. He wrote, "Do not get lost in a sea of despair. Be hopeful. Be optimistic. Our struggle is not the struggle of a day, a week, a month, or even a year. It is the struggle of a lifetime. Never, ever be afraid to make some noise and get in good trouble, necessary trouble." Beautiful people, thank you for the work you do every day. You are appreciated. We see you. You are valued. This is your conference. There is a reason we have this whole stage up here and graphics, because we're here to celebrate the work that you do every day. This is not easy work. We know it. So we want you to go home and be encouraged and supported and stick with this, because we sure as hell need you. Thank you for coming to Washington, D.C., and we will see you next year at STI Engage, which is going to be where, Elizabeth? We're not allowed to say. That was a joke, Elizabeth. I saw that panicked look. I am sometimes known for blurting out things that I'm not supposed to blurt out, and I'm under strict instructions. We are not announcing where we're going next year yet because we don't have a contract, but we're looking westward. Safe travels home. I declare STI Engage 2024 closed.